Sarah Thompson is a licensed acupuncturist, herbalist, doula, and functional medicine practitioner who specializes in maternity care through the functional medicine lens. One of her great passions and missions is to educate women and their providers to the vital role nutrition plays in pregnancy and labor outcomes. Through her nearly 20-year experience, she has provided care to hundreds of expectant moms, and she's now also the author, as of 2021, of a book called Functional Maternity, using functional medicine and nutrition to improve pregnancy and childbirth outcomes, as well as in 2024, she published her second book, a reference book for providers called Beyond Results, a practitioner's guide to functional lab analysis in pregnancy. She is an absolute wealth of knowledge when it comes to how to look at the nitty-gritty of lab results and really put all of these complex things together throughout pregnancy. Pregnancy is a time where a lot is happening in our body that I think a lot of people just don't even realize. And there are so many complexities that she puts together and really simplifies as much as she can and gives some amazing visuals and analogies to help you understand really how to look at things, how to know if there's a concern or not. And in this interview, we're talking specifically about anemia and particularly iron deficiency because it is so common in pregnancy, but can also be so complex in how to address it. And most providers are really not looking at it in the most comprehensive way. So it's an amazing conversation. I learned a few really great pearls from this conversation, and I think you're going to get a lot of takeaways. I feel like it's going to be one where you're taking a lot of notes and maybe wanting to go back and have her repeat things, which the beauty of podcasts is you can do that and really get a lot of amazing tips out of it to really maximize your ability to absorb iron, to hopefully prevent iron deficiency and anemia in general in pregnancy so that you can have the best outcomes and your baby can have the best outcomes. So I hope you enjoy it. All right, Sarah Thompson, thank you so much for being with me today.
Yeah, thank you for having me.
So first, I'd love for you to share a little bit about yourself and how you got into a fairly unique specialty of specializing in functional maternity.
Yeah, absolutely. So I've always used nutrition in my practice. I am by trade a traditional Chinese medicine practitioner. So we do a lot of focus on diet and lifestyle management when we're looking at patients. And I started off my practice working primarily with pain management, sports medicine, like a TCM bread and butter. And it was when I became pregnant with my own first child that I fell into the beauty of maternity care and also the downfalls and the pitfalls and the gaps in maternity care. See, I feel like a lot of people don't see those things until they're in it. And it was for me, it was 18 years ago as I was going through my own pregnancy when I wanted to, obviously, as most moms, take care of myself in the best way I could so that I could take care of my new child in the best way I could from the get-go. And I started to ask my providers all of the questions I had, hoping they could be that resource for me for nutrition, for all the diet and lifestyle stuff that I wanted to incorporate. And very quickly, I found that nobody was doing that. It was very limited information. It was just take a prenatal that has folic acid and don't eat lunch meat. And I'm like, really? I feel like there's got to be more, right? And so my why personality led me down the path of exploring how nutrition plays into the pregnancy physiology, exploring the pregnancy physiology. And just over the course of 18 years, I have found functional medicine and studied and trained in functional medicine, become certified in functional medicine, and done additional trainings in conjunction with maternity care. Because I think that the thing that I have found over this journey are things that every expectant mother should know, and every provider who works with pregnant women should know, probably more importantly than the women themselves sometimes.
Yeah, definitely. Oh, that's
Yeah.
wonderful. Yeah, it's great that nothing like major happened, right? But like I think it is that curiosity that leads a lot of us to specialize in areas, especially when it comes to women's health and maternity care in general, because it is those like this is how we do it. It's very regimented and there is a lot of unknown, especially when it comes to nutrition, because there isn't testing in pregnancy and all this. So yeah, there are a
Yeah.
lot of gaps. So I appreciate you taking the lead and really going into that and doing the research where there really needs to be a lot more even. Yeah.
And as you read the research, there is actually quite a bit of research available on nutrition and pregnancy outside of just dietary management, but like the clinical nutrition perspective, which is really what we focus on a lot in functional medicine, is how does nutrition affect and manage and regulate the biochemistry? And the biochemistry is life, it's function in the body. And if you add, we start to look at the research, there's quite a bit out there. It's just piecing it together has become the hard part, right? Nobody's really piecing it together to say, oh, look, we have this study and this study, we have this study and this study. How do those two come together? And what does that tell us?
Yeah, great. Today we're talking specifically about anemia, which, as we both know, like, it's very common in pregnancy, a really common issue. And I'd love to hear from you, like, why do you think it is so common and so widespread? And why does it really matter? Why should we care about being anemic in pregnancy?
Yeah, so anemia is obviously it's one of the most common complications seen in pregnancy, and it can be the foundation of a whole cascade or domino effect into other complications. If we are anemic, we can't get oxygen to the tissues effectively. So we don't have enough red blood cells carrying oxygen, then the tissues themselves become hypoxic. And hypoxia, of course, means things like the placenta can't transport and do what it needs to do for baby themselves may not have enough oxygen. They might not grow as well as they should. And we know that hypoxia is associated with other complications such as preeclampsia. We do see higher rates of preeclampsia in women who are anemic earlier in pregnancy. So it is one of our root causes. We're talking about functional medicine. We're talking about identifying root causes. And I always joke, it's like one of those wonderful little diagrams. Do you have this? Yes, go here. Do you have this? No, go here. And it's just going as far as we can to the bottom of that idea, that differentiation to figure out what is that root cause. And anemia is actually probably one of those little precursor conditions where we can still go further. Anemia is complex. It's not as simple as just iron deficiency. Although iron deficiency is considered the most common cause of anemia, we find other things that go into anemia. And when we're saying anemia, what we're really saying is not enough red blood cells or not enough hemoglobin on those red blood cells. And as practitioners, our job is to figure out, is the body not producing enough red blood cells altogether, or is it producing enough red blood cells, but they just don't have enough hemoglobin? That's already step one in differentiation. And from there, we can start to figure out what is the cause of that anemia.
Now, like, maybe to start from the beginning, what are some signs or are there ways to, like, clue someone into, okay, maybe this is a thing for me and I should
Mhm.
be looking further into that?
Yeah. So anemia symptoms, most of the time what you're going to be thinking of is fatigue. Right? If you don't have enough oxygen and the cells can't produce energy the way they're supposed to, so we have fatigue. And it's not just like fatigue as in I did too much fatigue. It's like you wake up fatigued, you go to bed fatigued, you don't have the oomph to do the regular activities. Maybe it's something like muscle fatigue, the shortness of breath, just going up the stairs and you're like, oh my God, oh, like my muscles are even tired. It's like my muscles can't even get me up there. That's the type of fatigue we're thinking about when we're thinking about true anemia-based fatigue. Some people can also get symptoms of brain fog. We can see lightheadedness and dizziness. We can also see things like restless leg syndrome in people who have anemia. And I know with most people, when they're thinking, oh, calf cramps, restless leg, I think nowadays they go magnesium. But in some of those cases and some of those patterns, it's truly like an anemia or iron based or even a B12 related type reason why we have that.
And with that, with fatigue being so common, fatigue is so common in pregnancy anyway. Is it, I think that I appreciate that you highlighted that. Okay, maybe you're not just tired all the time, or at the end of the day, it's maybe feeling exhausted when you're trying to do anything and your muscles are feeling really fatigued. I think that's a good clue of differentiating between just like, yeah, you're tired, you're creating a baby right now. That's a lot on you versus you could.
Absolutely.
Yeah.
Yeah, it's a very different type of fatigue than just like pregnancy-based fatigue. You're right. Like milking a baby is a lot of work, which means you have to sleep a lot. But normally people with like just pregnancy-based fatigue, they have bursts of energy, they have times, and that's, oh man, I gotta take a nap. It's a different type of fatigue versus waking up and just being like, I don't even have the energy for the day. This is debilitating fatigue.
Yeah. And now, what's the best way to test for anemia? And maybe we talk about like what's the conventional way that they're trying to test for it, and then maybe what's the ideal way to test for it.
Most everybody who's in any sort of maternity care is going to get the basics done, and the basics is a CBC. And a CBC looks at white blood cells and red blood cells and a couple of their different differentiating indices, such as mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, some of these sorts of things. Most everybody gets this panel done at their first OB appointment in that transition between first trimester and second trimester. So right around that 12-week mark. There's a lot of information that you can get from just that basic CBC, which is amazing. And I love to talk about lab work. It's one of my specialties within my specialty is reading lab work, especially from an early onset in pregnancy, to use that to predict later on. But usually from then on out, very little is done for blood work perspective, except for maybe what we call an H&H, which is the hemoglobin and hematocrit. The problem with the H&H is it's very limiting. Yes, you might have low hemoglobin. Maybe your hemoglobin is normal, but you're actually iron deficiency without low hemoglobin. If we'd run something else, we would have seen a different pattern. Without all of the other supportive indices, such as the MCV, MCH, and CHC, we're actually trying to make a diagnosis of anemia or why we have anemia with our hands tied behind our back. Oh, look, you have low hemoglobin. Let's give you iron, but maybe it's not iron deficiency. The other values within the CBC really help you figure out what could be going on. Is it microcytic or macrocytic? Iron deficiency presents as microcytic, then B vitamin deficiencies present primarily as macrocytic. And we do find that 30 to 40% of anemia cases in pregnancy are actually related and are more macrocytic to B vitamins. 20 to 30% are related to iron deficiency. And of course, when we're looking at nutritional deficiencies, I always say no nutritional deficiency travels alone. They always come in pairs. Right? Nobody likes to travel alone. So sometimes you can see mixed patterns where you actually have a B12 deficiency and an iron deficiency. And so treating it simplistically, oh, you have low hemoglobin, here, take some extra iron, may not actually be the best course of action for every patient. That's what we call a blanket statement protocol, right? So doing additional labs, such as the full CBC with a differential and these sorts of things, can really help you determine what's causing that anemia. Then, of course, it's always important to run a full iron panel versus just saying low hemoglobin equals taking an iron supplement. Not everybody is an iron deficient person. Testing the iron panel really gives you that good information. And then, of course, testing the iron panel at specific times in pregnancy helps you predict even sometimes, is this person going to become anemic due to an iron deficiency later in pregnancy? It's amazing what we can do with lab work if we know how to use it correctly.
And how about ferritin? That's something that I test regularly outside of pregnancy, especially. But is that something that we can look at in pregnancy also? Is that helpful? Is it different, like in how we're looking at it in pregnancy?
Absolutely. Ferritin is one of our best markers of our iron reserves because that's what it is. Iron or ferritin sequesters iron and holds it, suspended animation, and kind of leaks it into the system as needed to facilitate the needs of iron in the body. That includes making hemoglobin, but iron does a whole number of other things outside of just making hemoglobin. And so when we look at ferritin, we're looking at how much do we have in the bank? How much iron do we have stored up that we can use as needed for these different metabolic processes? And iron metabolism in pregnancy is super unique because it's unlike outside of pregnancy. Iron is toxic. I think people don't realize that. Iron is very toxic in the body. It produces hydroxyl groups, and hydroxyl groups are considered one of our most damaging reactive oxygen species or free radicals. And so our body is really good at regulating and controlling iron levels in the body, and ferritin is one of those ways. Iron that's stored in ferritin is actually quite neutral. It doesn't cause damage to the body. And so that's why our body does this little bit of regulation. So as we go through pregnancy, iron absorption changes, where it stores it, when it stores it, all these things are quite variable. And so ferritin is an important marker and we use it, but we use it at specific times in pregnancy. And we also know that ferritin levels are going to change at specific times in pregnancy based off of the physiology. So like you, ferritin is one of my go-to labs on my first round of blood work I do on somebody. I want to know what that ferritin is, right? Is it too high? Is it too low? Where are we at in that game? And how much support does that person need from an iron perspective as we roll through the rest of pregnancy? But it is a really good tool, especially if you do have somebody who is presenting with anemia. That's the first thing you got to rule out is how much iron do they have in the reserves? What are we working with?
Yeah. And then how a lot of those markers, like there's the conventional reading on it, on the lab report, it's saying this is what's normal, this is what isn't. In pregnancy, and particularly in different places in pregnancy, are there some places where you're really aiming for it to be or worried if it's maybe normal but not in an optimal range?
Yeah, absolutely. And that's where it gets really fun in pregnancy when it comes to lab work analysis is the lab values are going to change trimester to trimester. And then in different phases of the trimester, it's going to be slightly different. And hemoglobin is one of those that changes quite dramatically, and it changes based off of hemodilution. So in the first couple months of pregnancy, we have a 55% increase in the fluid, the volume of the blood. But the red blood cells don't increase with that blood volume. And so at some point, usually right around 20 weeks, we have this temporary anemic type pattern. And I'll have patients all the time who tell me during this time frame, they actually felt it. Oh God, I was like, that was the week I like really had the shortness of breath. I almost felt anemic. And you have to hit that mark for the body to be like, oh no, we forgot to make red blood cells. And then it increases red blood cell production by about 35%. And then we come up to a baseline. But that baseline is always going to be lower than we were preconception because we still have that element of hemodilution. So we have the first half of pregnancy where we expect this little change, right, from 12 weeks to 20 weeks. And then from 20 weeks on, we should see it kind of balance back out. So it's still lower than it was, maybe at that 12-week mark, but not so low that we're actually anemic. And as we look at what the research says is the magic numbers for hemoglobin, and we're just going to talk hemoglobin right now, is 11, 10.5, and 11, right? So first trimester, if that hemoglobin is at an 11 or above, we're doing pretty good. We're not considered anemic. At that 20-week mark or right around that point in second trimester where our ratios are off, that hemoglobin can drop to like a 10.5 and still be considered normal because we just caught this. It's not that we're actually anemic. We caught that normal ratio difference between the fluid and the red blood cells, and it's going to kick right back up, right? And so by the time we get to 28 weeks, we should definitely be back to that 11 and above. Now, we can also go too far the other way too, right? If our hemoglobin levels are too high, then we start to go, oh no, why are we so thick? We're not supposed to be thick. Why is there so much hemoglobin going on there? So then we start with thinking, oh, did somebody not produce as much fluid? Are they dehydrated? All those sorts of things. And when you run a hemoglobin test, you're not just testing the hemoglobin that's on a red blood cell. You're testing all hemoglobin. This includes hemoglobin that's loosey-goosey and not attached to red blood cells. So sometimes we can have these false elevations in hemoglobin because we actually have cell death and we have maybe some early preeclampsia stuff, or we have inflammation. You see this in people with autoimmune disease. And that hemoglobin is actually falsely normal or falsely elevated because of that. And it's not actually representative of functional hemoglobin. This is why some studies and some researchers will say that the mean corpuscular hemoglobin concentration, the MCHC, is more accurate in determining the hemoglobin levels on red blood cells than serum hemoglobin levels.
Makes sense. So you're seeing what's actually in the red blood cells on average.
Exactly.
Versus level. And are there any signs in particular that you would be able to see, oh, it seems like it is a cell death situation versus not? Would that be just looking at the whole CBC, looking at all the big picture?
Exactly. It's looking at the whole picture. Sometimes in those cases, you're also going to see changes in the immune system. You're going to be seeing changes in platelets as well. If we have an element of cell death or something like that from a white blood cell platelet connection, you're going to see a big drop in those platelets as well from the hemolysis perspective. Platelets live for about 8 to 9 days. And so we have quite a big turnover in platelets. And if they're dying too soon, you'll start to see that level come down, but you'll see the mean platelet volume increasing as we're releasing more baby platelets into the bloodstream. So that can be an early sign of that hemolysis component before we actually get to thrombocytopenia or really low platelet counts, or before we get to any bad things down the line.
And how about the other markers? Are there things on like the iron panel that you're like, I want to see it at a certain place, or ferritin?
So ferritin levels, if we're looking at that, anything less than 30 at 12 weeks pretty much predicts that somebody's going to be anemic later in pregnancy. We expect ferritin levels to drop. Ferritin levels drop by about 75% throughout the course of pregnancy. And this is actually considered normal because we're using all of that ferritin at different stages of pregnancy for different things. So by the time somebody gets to 28 weeks, there should have been a 50% drop in ferritin. And between 28 weeks and 36 weeks, there is another 20% drop in ferritin. And from 36 weeks to 40 weeks, ferritin levels go back up in preparation for labor and delivery. So there's wonderful little physiological changes that happen throughout pregnancy that go into regulating these ferritin levels and their big ups and their big downs. And I think in our world, we really want things to be flatlined, right? We like stability.
Yeah.
Our body does not like stability. It likes ups and downs. It's like cortisol levels. It wants ups, it wants downs. And ferritin and iron levels actually kind of are the same way. Our body wants to have a big storage coming into pregnancy. It wants to drop that storage in pregnancy, and then it wants to repair that loss in that last phase of pregnancy. And we do find studies that show that having a ferritin level slightly on that lower end of our normal ranges is more protective in pregnancy than being on the higher end because iron is toxic. There's a happy medium there. There's, again, functional medicine. Our idea is to keep us Goldilocks, not too cold, not too hot. And ferritin, to me, is one of those beautiful representations of that Goldilocksing, is making sure we're not getting too low, but we're also not going too high.
Yeah.
Because we'll also see studies that talk about high ferritin levels in the first trimester being biomarkers of things like gestational diabetes and preeclampsia later in pregnancy.
Yeah. It's so fascinating. And you're right. We would love for it to be textbook all the time, right? Be like, oh, it's just straightforward. It's always in the perfect spot. And I do see that all the time where sometimes we just can't outsmart the body and our body is doing something for a reason. And it's really fascinating to me to be able to like witness that and put that detective cap on and try to figure out why it's going on, what's going on, and taking all that context in. It's so fascinating, as frustrating as it can also be when we're trying to.
I know. Yeah. And I think iron, again, it's a wonderful representation of that because I say this every time I talk about iron. Iron is toxic. And so our body is really good at regulating iron absorption when our body is in a position in which toxicity could be a problem. And I think nothing better represents that than pregnancy. And we'll see iron absorption changing throughout pregnancy. In the first trimester, iron absorption, whether it's heme or non-heme, iron drops to about 2%, 1% max. Particularly between that 8 and 10 week mark when the spiral arteries of the placenta are opening up and we're transferring blood between baby and mom finally. Baby has been building up toxicity in its little cocoon of development until we get to this point by just going through the metabolical processes of cellular development. Every time we take calories and turn it into energy, there's a production of pollution. And that pollution has nowhere to go until that placenta opens up. And we want good, fresh, thin blood, oxygenated blood going to baby, but we don't want a lot of iron going to baby because iron is toxic. And so our body beautifully drops our iron absorption to that 1 to 2% during this time frame to protect our babies until we get the signal, hey, everything's cleaned up and now baby actually does need some iron. And we see that iron absorption then shifts back to its normal 35% for heme, 5 to 15 for non-heme in that second trimester. Then in the third trimester, things shift again. And we find that heme iron absorption stays at about that 35%, but non-heme iron absorption increases to almost 70%.
Oh, interesting.
Isn't that cool? So different than outside of pregnancy. And partly that's because our hepcidin levels go down. Hepcidin is less, it's almost like it's sleeping on the job. I don't want to do my job today. Let the iron in. I don't care. And we find that the heme-based iron goes almost directly to baby. So all that great red meat, those liver pates that people are eating, we're feeding the iron needs of our baby in the third trimester. And babies need to accumulate about 350 milligrams of iron as their stored ferritin during the third trimester to get them through their fourth trimester, so postpartum, when they can't absorb iron from breast milk or formula. They have to have this beautiful reserve to get them through that time frame until their gut is fully developed and they can start absorbing iron from their foods that they're consuming. And so most of mom's iron in the third trimester is going to baby, not her. She should have done all of her stuff she should have done in the second trimester, prepare for the third trimester. She will use the non-heme-based iron. Her body will use that more. And that'll go into all of her functions, whether it's thyroid health, enzyme production and function, little bit of RBC production. And then her ferritin stores, most of that heme-based iron is going to go to baby until baby has accumulated all of that iron that it's supposed to. And then the placenta says, no, thank you. That's enough iron for me. Mom can go store this again. That's why we see that extra 25% drop in ferritin in the third trimester with that subsequent increase after 36 weeks. So we see that increase just normal if we're just watching what happens and we don't touch it because baby says, I'm full. Thanks, mom. That was good iron. You take the rest of it. And then mom starts to store her iron for labor and delivery. So she has her reserve to recover from the blood loss of childbirth.
Yeah. Amazing.
It's so cool.
Yeah. I love it. With all that, with keeping that all in mind, it sounds like then it's so important to prepare, if you can, before pregnancy to have enough iron for yourself so your body can do this beautiful dance with iron and keep it regulated so you're not just behind the 8 ball trying to figure it out and not knowing like how much to do then if, your numbers are changing. So what can someone do maybe like before pregnancy if they have the chance? Like,
yeah. Obviously, the biggest thing is to make sure you're consuming enough iron in the diet, which I feel like in our society isn't much of a problem. We're just bombarded with iron-rich foods, whether it's fortification, red meats, all of those sorts of things. When we're looking at people who struggle with iron levels preconception, iron, again, is a very unique nutrient in the fact that we don't have a direct excretion method for iron. Once it's in the system, unless we get rid of it through sweating, like skin cell loss, or as women, menstrual bleeding. So those are our 3 primary ways that we get rid of iron in the body. And so if we people who are struggling with their iron levels coming into pregnancy, we think, okay, number 1, are we losing too much somewhere? Are we sweating too much? Are we losing too much blood? Right? Those sorts of things. And then secondly, we think, are we absorbing it? What's going on with the tummy? Why is the body saying, no, thank you, I don't want that iron? Is there a gut component there? Well, we see certain gut bacteria are associated with lower iron levels because they will steal the iron and use it for their own metabolic needs. We find certain dietary patterns, and it's interesting that it's a lot of our healthy dietary patterns are associated with low iron, and that's usually diets that are high in things like oxalates. Raw spinach people are putting in their smoothies, that almond milk that they're consuming every day. Those guys are high in oxalates, and oxalates bind to iron and pull it out of the system. Let's see, what are some of the other things? Low stomach acid. Some studies will say that low stomach acid is one of the number 1 causes of low iron or difficulty with iron absorption. So there's a whole list of things that somebody can look at, especially if they are somebody who struggles with their iron levels outside of pregnancy. Because if they're struggling outside of pregnancy, there's a solid chance they're going to struggle in pregnancy. So outside of pregnancy, it's looking at, hey, what are my iron levels? Like test, don't guess. That's always our first line of defense. See what you get a baseline. See what your iron levels are at. What is your iron store? If it's on the lower end, let's start addressing the why behind that. How's your gut? Do you feel like you're actually getting enough iron in your diet? If you are, then let's look at maybe why you're not absorbing it. The other thing is, again, I'm going to say it one more time. Iron is toxic. And if the body has an element of inflammation, there's a specific cytokine called interleukin-6. Interleukin-6 increases hepcidin production, and hepcidin, when high, blocks iron absorption. So in people who have systemic inflammation and their body is producing higher levels of interleukin-6, they're going to block that iron absorption regardless of how much somebody's eating, regardless of supplementation, and regardless of gut health. Their body's going to say, hey, I don't want that iron right now because that's just going to produce a hydroxyl group that I don't want to deal with because I'm already dealing with some cellular inflammation. So as soon as I clean this, we'll fix this. But if we don't clean this up, no amount of iron supplementation is going to help. And those cases, sometimes when I have like clients in pregnancy who, like I feel like this is all systemic inflammation, I worry when they get their iron infusions because that's oftentimes that treatment protocol that we do when people get really low and they're like severely anemic with iron deficiencies. We say, hey, let's just bypass your gut. Let's put them in an IV and let's just give you a big old bump of iron. If they are already inflamed and we do that, they're going to feel that. And it doesn't feel good. And I've had some patients have negative reactions to their iron infusions because of that.
Yeah.
Because we didn't look at the root cause. We just said, we're going to fix what we see. Sometimes you have to do acute crisis management, right? Because in pregnancy care, you're dealing with 2 people. You got mom, but you've also got baby, and baby has to get that iron. Otherwise, they're going to struggle with anemia later.
Yeah.
So it's a tough game. So prevention is always easier than treatment. So anytime we can get people to do the preconception work and set themselves up for better success as they come into pregnancy, that's always going to be better.
Mm-hmm. Yeah, definitely. And so again, to reiterate, looking at their actual iron status, maybe nutrient markers in general, right? Because like you said, there are B vitamins that are so important with anemia and just our
Absolutely.
and their
Thyroid health.
gut health and inflammation.
Yeah.
Yeah.
I don't think people realize that hypothyroidism or thyroid issues in general play a big part in anemia. You have to have thyroid hormones in order to make red blood cells, white blood cells, and platelets. And so I've seen patterns in the past where white blood cells are low, red blood cells are low, platelets are low. And then we test their thyroid, and sure enough, that thyroid's under functioning, and we give them thyroid meds because that's just what you do in pregnancy when you have a hypothyroidism pattern, and everything gets better because that was the cause, not the iron deficiency.
Yeah.
And if we hadn't done our due diligence at looking and we just said, oh, look, low hemoglobin, here, take some iron, we would have missed what was actually going on and not actually helped that patient.
Yeah.
So preconception, it's looking at all of the factors that go into red blood cell production and hemoglobin production when it comes to the anemia side.
Yeah. And do things like you mentioned absorption and the factors that go into that, and a lot of that is gut health and the stomach acid, making sure that's all dialed in. Are there other factors that people need to worry about with absorption, or on the flip side, things that can help with absorption when they're getting those like red meats and things you mentioned?
Yeah, obviously, heme-based iron has less steps in its absorption, still about a 35% absorption rate. If we get a big bump of iron into the system, we will get a big burst of hepcidin that no matter what form it is, it's going to say, well, I got to process that first. Come back later. Vitamin C is one of our biggest supporters of iron absorption, mostly from that non-heme iron absorption side. You have to have adequate vitamin C, stomach acid, right? That vitamin C, ascorbic acid, it's acidic. It changes that environment. And there are studies that show that just taking vitamin C can negate low stomach acid and its effects on poor iron absorption, because not only does it change the acidity of the environment, because iron has to have an acidic environment, but it's really important for the conversion of the forms of iron, right? So most iron comes in a form called Fe3, and we can't absorb it unless it's in an Fe2 form, so it has to be reduced. Vitamin C, stomach acid, they help reduce that iron to allow it to come into the gut. So vitamin C is and this is why you'll see iron supplements that have vitamin C already added into them. So that's one of the things. The other thing is we find that iron absorption is best first thing in the morning. As we go throughout the day, our ability to absorb iron gets less. And it has to do with that hepcidin again. So as we get iron into the bloodstream, hepcidin starts to increase, and then it finally goes, dang, I've met my threshold for the day. I have to process this. Once I've processed this, then we can open it up for absorption again. And it takes about 24 to 48 hours for that to come back down. Right? So this is why I find if you're going to do iron-rich foods, do them first thing in the morning. Take your iron supplement first thing in the morning, steak and eggs for breakfast, right? You're going to get more iron out of that steak at breakfast than you are at dinner. So there's a couple of these little tricks like that you can do, right? That helps with absorption. Some other minerals block iron absorption because they compete through the same transport proteins in the gut. Calcium is one of the bigger ones. And so we'll oftentimes say, too, if somebody's struggling with iron absorption, don't take a calcium supplement with it first thing in the morning. Don't eat calcium-rich foods first thing in the morning, right? So we kind of switch their diet up a little bit to help.
Yeah, great. And how about, especially with iron supplementation, more and more I'm hearing people talk about the like every other day supplementation for iron. Is that the same reason with the hepcidin, or?
It's exactly why. Yeah. So again, we find I have this horrible analogy that I use, and I can use it. It's the way I describe it. I'm such a visual person. So I think of everything as like an event, a story. And to me, hepcidin and iron is like me having a water balloon fight with my kids, but they're in an elevator. And the elevator doors are the gut's ability to absorb. And like any good parent, I want to soak my kids with water balloons. I don't want to sprinkle them. I don't want to hit the wall behind them. I want to get them wet. And the elevator doors are that hepcidin. And so the water balloons are the iron. So if I am trying to get as much water or iron into this elevator and really saturate my children, then I have to wait for those doors to open up all the way. If I throw it in there too soon, they're going to push that button, right? And I might get a balloon through there. But if I'm patient and I wait 48 hours versus 24 hours, right, then I'm going to wait for that hepcidin level to open up all the way. My kids may even stick their head out the door and be like, "You guys see Mom? Where is she? I don't know, maybe she left." And then I'm just going to throw a bit of water balloons at them. By the time that door closes, I have gotten a huge dosage into that elevator. This is why when we see those studies that say doing a dosage of iron and doing it every other day is as effective, if not more effective, than doing heavy doses multiple times a day without the gastric side effects. This is why I've seen patients come in and their provider has given them dosages of like 375 milligrams of iron a day, broken into 3 doses, and they have constipation, they've got gut issues, their ferritin levels aren't changing, and their provider's just saying, take more. That's not the answer. All you're doing is keeping that door shut. That body's, no, are you kidding me? I'm not opening this door. Every time I do, they say that. If you give them smaller dosages, say something as simple as 30 milligrams or less, every other day, we're getting more through the system when we do that. We might get all 30 milligrams in before that door shuts. Then the body can process it. Keep knocking on the door, it's not going to open.
Mm-hmm. Yeah.
So that's that idea of why what we see in research, we apply it to the physiology.
Yeah, I love that visual. I think a visual is always more helpful because especially when we're talking about biochemistry type stuff, it can make us gloss over and just go right over our heads. But the good analogy, I get that. I get the elevator doors. So that's great. And with that too, I mean, with in terms of supplementation, are there certain types then too that you're recommending over others, keeping in mind the gastric side effects and things like that too?
The iron ferrous sulfate tends to be what we use with a vitamin C, right? There's a specific form called Ferrochel, Ferrochel. That specific form seems to have the best absorption rates. That's what I tend to give people. There's a specific product I use. It's a brand called Metabolic Code. No, I don't get any like affiliate stuff with this. I just literally think this product works really well. Metabolic Code, the product is Hemeplex, and it's a simple formula. It's Ferrochel and vitamin C. All it is. And I have seen it work more effectively than any iron supplement I've used in patients. I might have a patient who comes and they're like, I've been on an iron supplement and my ferritin levels aren't changing. And I switch them to this one and it works. And it's simple. It's a low dosage. It's 27 milligrams. And we have them do it maybe every day, but usually every other day. And we get better results like that. So that's the form that I personally gravitate towards. And then in pregnancy, like diet-wise, we're talking a lot to them about iron absorption as it pertains to the individual trimester. Most people who are presenting with iron deficiency, it's going to be in the 3rd trimester. That's when they're going to get diagnosed with it. And they're only going to get diagnosed with it generally in conventional medicine once their hemoglobin has already hit a lower weight. We're already in that anemia category. If we can catch it earlier, we can prevent that anemia. That's the goal. That's always the goal in functional medicine, is what can we do to prevent the complication? I don't like dealing with acute crisis management. Like, I hate it when patients come to me and they're like, I already have all of these things. I'm like, oh, God, okay. There's so many things we could have done before this. All right, here we go. This is just, we have limited time. We got to hit them hard. It's not fun for anybody. If we were to do more lab testing at the beginning of pregnancy and get these baselines and know how somebody is coming into pregnancy and how 1st trimester treated them, we're in a way better position to prevent those 3rd trimester complications. So ideally, people can come in and do that to get their ferritin baselines, see what their hemoglobins and stuff look like. Look at other factors too. B6 deficiency looks and acts just like iron deficiency on paper because it's one of the enzymatic rate limiting steps in hemoglobin formation. So understanding that whole pattern earlier on really helps people later on.
Yeah, that's great. And how do you prefer testing for B vitamins? Because I know that's one area where I see people come in and they're like, I got my B12 and folate and they're normal or they're high. And they're like, so I'm not, and then end of story in their
Yes.
eyes.
I don't love serum values. I like functional values. So I use a lot of testing that looks at the end game. When you have B12 and folate and they're being used in the system, we're going to have specific other things that we can test for to show that B12 and folate did their job. They produced these specific compounds, or they did this and we see this functionally over here. So it can be simple things, honestly, like methylmalonic acid is a really good one for seeing if B12 is actually adequate. Is the body actually using that B12? One of the problems with serum levels too is that it tests what somebody ate, their supplements, all of that. So in order to get a really good baseline on a serum level, You have to have somebody off their supplements for several days. They have to go in fasting. Sometimes that's really hard in pregnancy. But if we look at those functional values, we can see what those nutrients have been doing over a specific time frame. Whether, it's homocysteine, methylmalonic acid. For B6, I'll use things as simple as the CBC and the metabolic panel personally, because I think you can see it in there, right? If you have a lower RDWs, which is the red blood cell distribution width, that's more indicative of a B6 deficiency, where higher RDWs are more indicative of an iron deficiency. So we can look at these little things, if you know how to read it, to help you differentiate and distinguish the different nutritional deficiencies without trying to run those nutritional panels. On the comprehensive metabolic panel, we find that the liver enzymes can be really good markers of things like B6 and zinc and thyroid function to some degree, because you have to have B6 and zinc and thyroid hormones in order to metabolize proteins. And so if you have low ALT, low AST, low alkaline phosphatase, those guys can be markers of those different either nutritional deficiencies or hormonal patterns.
Yeah. So cool. And I love being able to like multitask with those types of tests, because they are so simple. A lot of people have already had them done. And so if you can just look at them and draw more information out of them, that's so valuable.
Yeah. I think especially in pregnancy, that's more valuable than trying to run a lot of these functional medicine tests. Because again, time is of the essence. These are usually labs that people have had done. You can get their baselines of what they had done preconception, compare it to where they are in pregnancy. And okay, is this your norm, or did we see something change? And it's one of those things too, like to run a lot of blood work, that takes a lot of vials of blood. And if you have somebody who's already anemic, the last thing you want to do is keep stealing their blood to test for things. So if you can look at what you already have, and the basics too, a CBC and a comprehensive metabolic panel isn't much blood to take. And if you can use that and get a really good picture of what's happening and understanding things, then you're really helping them twofold, right? If you can read that, you can get the right diagnosis and get the right treatment, but you're also not making them worse if they're already anemic, because that's just more blood they have to try to regroup from when they already don't have enough.
Yeah. Love that. Now, to kind of take it back to like just a practical standpoint, because I think you've provided so much valuable information and really interesting aspects to this whole picture, to kind of take it back to that person who maybe they're listening and they're like, oh, I'm suspicious I'm anemic, or I just found out I'm anemic. Maybe let's say that she's in the first trimester. To maybe reiterate, what would be the top 3 things that she...
Yes, sure. So if somebody was like, you said first trimester and they found out they're anemic,
or if there's a certain point where you're like, okay, I see it all the time in this like second trimester, let's do it there or wherever.
I think at any point, if somebody finds out they're anemic, the step 1 is to figure out what's the underlying cause. Is it iron deficiency? Is it just iron deficiency? And then what are the other components, right? Is it B vitamin, zinc, copper? Nobody ever talks about copper with anemia, right? Vitamin D deficiency can cause anemia. There's a whole slew of things, right? So the first step is, if you can get your provider to run some more labs, figuring out the why behind that anemia. Thyroid, check that TSH. I mean, something as simple as that. I know it's not a full comprehensive thyroid panel, but it can still give a clue if somebody's anemic. Again, we're trying to do what's the basics we can do to get the most information to make that decision on what's the cause. And if somebody's anemic, we should have a whole panel, not just an H&H, to look at the MCV, MCH, and all those things to determine, is this a B vitamin component, an iron component, what have you. That's the first step. Then from there, it's eating for total hemoglobin production, not just iron deficiency, because iron deficiency rarely comes alone. If they're not absorbing that iron, then we go back to gut health. How do we help that gut health? If it was somebody who was like, I just found out I'm anemic, what are all the things that I can do? It's obviously take an iron supplement, right? Maybe pick up a cast iron skillet. Start cooking in a cast iron skillet every day. Cut your oxalates back. Increase some vitamin C and acidic foods. Cook your anything iron related, put some acid in there. Lemon juice. Lemon juice goes a long way for this. Those would be some of the gut stuff. A probiotic may help. I'm not a huge probiotic supplement fan, but I will say fermented foods, right? Add some sauerkraut to the mix. Do some kefir later in the afternoon. Don't do that dairy first thing in the morning with your iron supplement. Do it later. Do all those sorts of things. And see where it gets you.
Yeah.
Right? Try to focus on that aspect of things as best you can.
Yeah.
And then, of course, test, don't guess.
Yeah.
Fight for that testing.
Yeah. That's so practical. And I honestly love that with just taking a more like knowledgeable approach, like doing that testing and really looking at those pieces of it, I think it also simplifies it a lot rather than like you described a patient, probably several patients you've had already where they're like, I've been taking everything and it's not working. It's probably like you could take it less and just do it in a more smarter way. And it just becomes easier. And that's one aspect that I love about it. People feel like, oh, it's going to get more complicated. The more information I have, it's going to get more complicated. In reality, it could be way simpler for them to just, oh, just do it in a certain way. And it could be bigger bang for your buck, so to speak.
Absolutely.
And we talked about some potential mistakes people could make, not intentionally, maybe taking their iron supplement at night or with their calcium or whatever. Are there any other big common mistakes that you see that we haven't addressed at this point?
Ooh, Tally, that's a good question. Not particularly. I would say the biggest ones is I don't love prenatals that have iron mixed in them already. I always do it separately because there's a lot of competition between more than just calcium, but other minerals in iron absorption. So I just find it's easier and better to have an iron separate and to take it away from the prenatal in of itself. First thing in the morning, empty stomach, add something acidic with that. Wait a couple minutes, 30 minutes to an hour before you eat breakfast. That's the generalized thing, low oxalates. I think the oxalates is one that gets people a lot. Again, with like the modern health kick diet stuff, lots of smoothies is what I see. And if we're doing raw greens in those smoothies, those oxalates really will bind to that iron and kick it out.
Yeah.
Yeah.
And I think that's one thing that a lot of people really have not heard of. Even people who are very educated when it comes to health, they're like, oxalates, what the heck are those? So I think it's a really key point that you're mentioning that. And I guess with one way, so like you said, they're basically a type of crystal that are found in a lot of different foods. How can people work around that? One thing you said, just maybe
Sure. Yeah, so sometimes we'll say just avoid them altogether. But for the greens, and again, spinach is the biggest culprit when it comes to the greens. There's just a lot of oxalates in there. And cooking spinach will reduce the oxalates, but only cooking it in specific ways. It's blanching. And what blanching is having a pot of boiling water, throwing the spinach in there for 2 to 3 minutes, draining it, and squeezing all the water out. If you cook spinach, all that, those oxalates are going to go into that water. So if you throw spinach directly into a pot, you're still going to get those oxalates. It's just going to be not attached maybe to the spinach anymore, but it's going to be in the juice within that meal. So blanching is a really important part. And we find studies that show that blanching grains, specifically spinach, reduces about 90% of the oxalates in them because you just put them down the drain. Then you add it to things. Maybe you then freeze your spinach and then you can add it to your smoothies. Not a huge smoothie fan, but we could talk about that in a minute. Then you add it to your scrambled eggs in the mornings, or switch your greens altogether. Switch it from spinach to arugula. Arugula is a low oxalate grain, right? Do arugula in your eggs instead. So there's these little switches that you can do. I also find like nut butters, like almond butter tends to be one that's one of them. I brought that up, biggest culprits. I use my dad as an example about this. He'll be mad at me that I'm talking about him on podcasts. But I joke, my dad had a kidney stone recently. He only has one kidney because he had kidney cancer years ago. But my mom had switched their milk from cow's milk to almond milk because like, oh, it's healthier and this, that, and the other. And he developed a kidney stone. And I was like, oh my gosh, Mom, what are you trying to do? Kill him? Like, I went to their house, opened up the fridge, and it was just like 4 containers of almond milk. And my dad was so proud of himself and getting like calcium and all the things. I'm like, stop. This is why you have a kidney stone, right? Kidney stones are primarily calcium oxalates. Almonds are high in oxalates. Not only do oxalates bind to iron, they bind to other minerals like calcium and different things like that. So they do have a high propensity for making kidney stones in large amounts. But yes, the oxalate game. So if you can't break down oxalates, it's going to bind to that iron, kick it out of the system, and cause some issues there. But almonds are another one that we see as a big culprit. And almond milk, that's all it is, just oxalate water. That's all it is. You've soaked almonds in water, which releases the oxalates into the water. So it's another one that I see as a big culprit sometimes of that iron deficiency game specifically.
Yeah. And some people are more sensitive to oxalates in general.
Sure. There's a specific bacteria called a bacteria in the gut, and its job is to break down and neutralize oxalates in the diet. Some people don't have this bacteria, which makes them more sensitive to oxalates in the diet. And obviously you could do stool testing and you can do some things that identify whether or not you have this specific probiotic strain, right? We don't have probiotic supplements for it yet, but it is something that I will see in clients who are preconception. They had a history of anemia in previous pregnancies. struggle with their iron levels outside of pregnancy. And then we do a stool test, and sure enough, they don't carry this bacteria. And so we talk about that and say, hey, like you really have to be diligent about going through the preparation methods that reduce oxalates in your diet. Souring grains reduces oxalates. So there's a lot of preparation methods that humans have actually used for a very long time when working with foods that are high oxalates that we just don't, because we've either lost that knowledge or we just don't have the time to do it. But humans knew what they were doing a long time ago. We've just gotten slow. But souring the dough, soaking the grains. We even find pictograms in Aztec ruins that talk about soaking legumes.
Interesting.
Right? The process and how they're supposed to go through it. It's like they totally knew these things. So there are methods. And if you are somebody who is low oxalate struggling with iron, this is something we do focus a lot when we're talking about that diet and lifestyle modification. This is just you. And you have to do these things in food preparation in order for you to get the maximum out of your food.
Yeah.
Some people don't have to.
Yeah. So not everyone has to avoid almond milk like the plague.
Yes.
But like you said, if they are having an issue with their iron, especially a repetitive issue that isn't correcting,
Right.
maybe they've done some testing and their oxalates are high. There's some there that can make some.
Exactly. And on the opposite side, when we have people who have high iron levels, people who carry hemochromatosis, henes, and those sorts of things, we have them increase their oxalates with the idea of binding to that iron to prevent that absorption because they don't have a good regulatory hepcidin system. Their genetic expression of hepcidin is broken from a genetic perspective.
Yeah. Yeah. Cool. I love it.
It is.
Any other like takeaways that you'd want to share? Maybe just like for a pregnant woman about maybe preventing or managing iron deficiency or anemia?
Yeah. Oh, again, there's so much more than just iron. And variety is key. So, like from a dietary perspective, get the heme and the non-heme based iron food sources. Don't focus on just one. I think that's important. And I think the biggest thing is prevention is key.
Yeah.
Anytime we have a pregnancy complication that arises, we have to look back 3 months before. That's when the actual problem started. By the time we have the problem, we've probably been dealing with it for a while. We just finally got to the point that the body said, I've had enough. So prevention is key. So anything that they can do to get the testing, to do the dietary stuff, make sure they're eating what they need to do, especially if they've had issues in the past, that's going to be their best line of defense.
Yeah. Awesome. And I completely agree with that. I think we should need to shout that from the rooftops. Prevention.
I know.
Got tested. Look at things beforehand when you can. So much easier to address things that way.
Absolutely.
Awesome. Sarah, this has been, again, so helpful. I think this is going to really help a lot of women out there. Where can people find you if they want to learn more from you? You have a fabulous book about maternity care for the functional lens.
So I have 2 books. My first book is Functional Maternity, Using Functional Medicine and Nutrition to Improve Pregnancy and Childbirth Outcomes. And I have a whole chapter on anemia in there. I believe it's chapter 9. And so if people are interested in learning more about the complexity of anemia, I try to break it down into here's how red blood cells are made. Here's all the things that go into that. There's a lot of useful, I think, information there too on how people can change those outcomes. My second book is Beyond Results, and that is a practitioner's guide to lab analysis. So using those labs to look for those patterns and understanding the physiology behind the lab value. So those are my 2 books. People, if they want to know more about the research side of things, nutrition, functional medicine, and maternity care, they can follow me on Instagram. I always post research-based information there. It's at functional.maternity. And then people can also visit my website, which is functionalmedicine.com or functionalmaternity.com. Yeah.
Perfect. Thank you so much. Yeah, the information you provide on Instagram is always so helpful. And I really do appreciate that you speak to the practitioners as well, because I agree with you. I think that's really where the money is when it comes to changing the whole system, because women could have all the knowledge and then go to the practitioner to give them the strategy. And then they're still like, they're just going to test an H and that's it. And I don't know what to do. So I really think change needs to come from the practitioners really understanding how to do this and understanding the nuance to it.
But I think that's good for people to hear, because most of my focus in what I do and talk about is geared towards the practitioners and less towards the mom, because I think that's who we have to talk to too. We have to get them to understand these changes. Otherwise, women can come with all the information in the world, but if the provider doesn't know it, they're not going to listen to them, unfortunately.
Yeah.
So that's my goal. So if people are following me on Instagram, they'll notice that things are geared a little bit more to the practitioners and helping them use their critical thinking brains versus here's a protocol. I don't do protocols on there. So people are looking for that. Don't go there.
Mhm.
I also, through my clinic, do offer free 15-minute phone consultations. So if people have little questions or want to know how functional medicine could help their specific case, I do free 15-minute phone calls. So they can always call the office and schedule something with me directly.
Awesome. And where are you located again?
I'm in Colorado.
Yeah. In
Yeah.
which town?
Fort Collins is where my office is. Yeah.
Okay, cool. Wonderful. Again, thank you so much, Sarah. This has been so much helpful information. I think people are going to take a lot away from this and probably are going to be taking feverish notes and then have to listen back a few times, but in a good way. So I really appreciate you taking the time to be here and just sharing this information with everyone.
Of course. My pleasure. And thanks again for having me.
Yeah.